The next one is going to be on Tuesday, the 6th of April, and then we are going to stop for the holy month of Ramadan and then come back after that. And Congenital Heart Academy is proud to support the Fetal Heart Society. So we are going to have on the 8th of April, next Thursday, this very, very nice meeting talking about fetal TGA. So please join us on that. On the 12th of April, Professor Mary Cohen is going to talk about ECHO for coronary artery anomalies. I'm sure this is going to be very good. And Dr. Silverman is going to talk about tetralogy of Fallot. He's going to correlate the morphological images with echo images, as he usually do. His sessions are always very interesting. So please join us on 19th of April to talk about tetralogy of Fallot. Dr. Gilvernovsky is going to continue with his amazing series. On the 27th, we just changed the topic. It's not going to be tetralogy of Fallot. We are going to continue the TGA. On 11th of March, we started with TGA, but discussion was so amazing that we're not able to finish. So we talked about the transitional circulation and preoperative care of transposition. And now we are going to talk about the post-op care of transposition on the 27th of April. And to finalize the month, we are going to have our fourth meeting of the fetal cardiology series. We are going to talk about the update on fetal cardiac interventions. So we are going to have three amazing speakers from all around the world telling how are their experience with fetal intervention. So please join us on all of those activities, and please enjoy today. We are going to have a very nice topic today, and we are going to have amazing panelists for the discussion in the end. Please type all of your questions on the Q&A chat box. We are going to be happy to answer all of them in the end of the session. Thank you, guys.
Well, good afternoon to you all, ladies and gentlemen, and welcome to another of our sessions for the Congenital Heart Academy. Those of you who have been following us will now know we've been engaged in these sessions for getting on for a year. And during that time, we've been trying to understand the congenitally malformed heart. So what have we needed to do to bring this understanding before you? Throughout that time, I've been discussing the basic anatomical arrangement. And I've also been discussing the features in the setting of normal anatomy. You'll be aware that in recent years, or rather recent weeks, I've also been concentrating on the way the heart develops. Because there's no question that if you understand the way the heart develops, and you understand what can go wrong, that gives you an insight into the anatomy that confronts you when the heart is congenitally malformed. Those of you who are regular attenders will now know that we are revisiting these morphological arrangements. And so to do that, we've been looking at the normal anatomy, we've been comparing it with the abnormal anatomy, and then I've been concentrating on that morphogenesis, and you know that I've been using the wonderful PD files for normal cardiac development that have been created by Professor Wout Lammers and Dr. Joel Hickspoors from the University of Maastricht in the Netherlands. Well, now, over the last few weeks, we have been going again over the anatomy. And so we have been revisiting those lesions. And in recent weeks, we've been looking at hearts with dominant left ventricles, dominant right ventricles. We've been looking at that in the setting of the functionally univentricular arrangement. And then last week, we were looking at hearts with straddling atrioventricular valves. Well, for the month of April, we're going to continue these revisitations. And today, we're going to start off by looking at atrioventricular septal defect. And then next week, we'll consider tetralogy of Fallot. We'll move on, we'll look at common arterial trunk, and then we'll finish the month of April by looking at what's going on in the setting of congenitally corrected transposition. And we're going to concentrate then on the discordant atrioventricular connections. And throughout that time, I'm going to try to discuss with you how the anatomy is related to the morphogenesis. Well, those of you who have been watching recently will know that this is now very much a collaborative effort. And as we move forward, I'm joined by my colleagues. And in particular, over the last few weeks, I've been joined by Diane Spicer. Now, I thought I should tell you a little more about Diane. So I've known Diane now for a very long time. I first met Diane when she was training to become a pathologist assistant at the University of Pittsburgh in 1982. And she moved about 10 or 15 years after that to Florida, and she's been in Florida since that time, and she has become a consummate anatomist in her own right. And you're all well aware of that because you have now been seeing wonderful presentations she's been making to show you the anatomy of the congenitally malformed heart. And she's now doing that from her new position at All Children's Hospital in St. Petersburg, Florida. And now we're joined also by Adrienne Cruchan. So I thought I should tell you just a few words about Adrienne, because I've known Adrienne since I moved to Great Ormond Street in 1999. And Adrienne was one of the first surgical fellows who came to train at Great Ormond Street during my period there. And Adrienne is initially from Romania, and he is a consummate surgeon in his own right, but he is now also concentrating on the anatomy of the congenitally malformed heart. So Adrienne brings the great advantage of being able to look at the anatomy from the stance of the surgeon. And he's now a staff surgeon at Birmingham Children's Hospital. And he and I have been putting together over the last 5 or 6 years the wonderful archive of congenitally malformed hearts that they have in Birmingham. So Adrienne is now going to be joining us through April. He's going to join together with Diane and I, and he's going to demonstrate to you congenitally malformed hearts from the Birmingham archive. So today, we're going to start this collaborative effort with Adrienne coming in at the end to show a live demonstration. And we're going to tell you all about atrioventricular septal defects. We're going to talk about the anatomy of atrioventricular septal defects, and I'm going to try to relate that to the morphogenesis of these lesions. So we need to start off by asking, what is an atrioventricular septal defect? Because as you'll see, the situation is not quite as simple as it might first seem. So an atrioventricular septal defect is any channel within the heart that permits shunting between the atrial and the ventricular chambers. And the key here is that very rarely you can have that situation when the shunting is in hearts that have separate atrioventricular junctions. And these are the defects that we call the Gabodi defects. We don't have any of these hearts to show to you today, but I'm going to describe to you what's going on with the Gabodi defects, and those of you who have been following our previous presentations will know we've already discussed this. But you're also very well aware that far more frequently nowadays, the situation that we call atrioventricular septal defect has as its phenotypic feature the commonality of the atrioventricular junction. So we're going to try and put that today into the context of normal atrioventricular septation and explain to you why it is that the atrioventricular septation can go amiss. And it all comes back to the process we've been discussing several times over recent weeks remodeling of the primary interventricular foramen. So by now, I hope you all know that it is remodeling of this initial channel that we see in the developing heart that provides first inlet to the right ventricle and then the outlet from the left ventricle. And the key features eventually enclosing the interventricular foramen, and that is the tertiary interventricular foramen, are tubercles from the atrioventricular cushions. And today, as we seek to understand atrioventricular septal defects, we're going to be concentrating on these atrioventricular cushions. But what I'm also going to show you is it's not simply the fusion of the atrioventricular cushions and the fusion of those tubercles to close the tertiary interventricular foramen that ends the sequence of development. There is ongoing development subsequent to that stage, which produces the normal definitive atrioventricular junctions. So let's first of all remind you what we mean when we talk about the primary interventricular foramen. This is a picture you've seen several times now. It's a cut showing you the base of the ventricular mass in the human embryo at Carnegie stage 14. It's one of the episcopic data sets prepared by my other very good friend and collaborator, Dr. Tim Mohan. So we're looking at the base of the developing ventricles from the stance of the apex. And there we see the undersurface of the atrioventricular canal. And by now, you all know that at this early stage, the atrioventricular canal is supported exclusively by the developing left ventricle. So all the blood entering the developing left ventricle has to pass through this channel to reach the right ventricle. And so this is the primary interventricular foramen. And at this early stage, the entirety of the outflow tract is supported by the developing right ventricle. So this is Carnegie stage 14. We'll come back to that in just a moment. But if I switch to a mouse heart now, and this is the later stage of development in the mouse heart, where the developing right ventricle has now acquired its own inlet, and it's done this by remodeling of the dorsal part of that primary interventricular foramen. So now we can describe the persisting interventricular communication as the secondary foramen. But remember that at this stage, developing aortic root is still positioned above the cavity of the right ventricle. But that expansion of the atrioventricular canal has also taken the major cushions into the right ventricle. And this is the key to what we're going to be looking at in the setting of atrioventricular septal defect with common atrioventricular junctions, because the cushions now bridge across the ventricular septum. And you can see rather nicely that bridging process in this view of the mouse base of the ventricular mass, again as seen from the apex. So there's the superior cushion, and there you see the inferior cushion draped across the crest of the muscular ventricular septum. On both sides now, we have a lateral cushion, so that's the right lateral cushion, there's the left lateral cushion, and the key with regard to atrioventricular septal defect, the common atrioventricular junction, is this early situation where the cushions have a trifoliate configuration within the left ventricle. And part of that trifoliate configuration is the zone of apposition between the superior and the inferior cushions within the left ventricle. And we're going to come back to that. But let's look at what happens in the interactive PD files. So again, these are the files that have been made by Wout Lammers, Jill Hickspoors. So here we're looking down at the human embryo at the stage where the atrioventricular canal, which we see there, surrounded by its canal myocardium in yellow, is supported by the developing left ventricle. Within the canal now we see, as we look down on the junction, the right ventricle, but within the canal itself, we see the superior cushion, inferior cushion. We can also see that Wout and Jill have colored in another structure, and that is the leading edge of the primary atrial septum. And on that leading edge, there is more endocardial tissue, which we call the mesenchymal cap. And that itself is going to be significant, as you will see as we trace this forward. The heart itself retains its connection with the pharyngeal mesenchyme, and this is what we call the dorsal mesocardium. And the dorsal mesocardium at this stage is connecting the back of the atrial segment of the heart to the pharyngeal mesenchyme. But if we move on, we need to look at what is happening to this space between the leading edge of the primary septum, the atrioventricular cushions, because that is, at this stage, the developing atrioventricular septal defect. So if we move on a couple of stages, so here we are, Carnegie stage 16, now the canal has expanded. So as in that situation I showed you in the developing mouse heart, the superior cushion, the inferior cushion are now draped across the crest of the muscular ventricular septum, with the right ventricle having developed its own inlet. The primary septum, along with the mesenchymal cap, has grown towards the margins of the atrioventricular cushions, and that is reducing the size of the primary foramen. But here now is the key point of development, because growing through the rightward margin of that dorsal mesocardium is the structure we're going to call the vestibular spine. And what I'm going to show you is that it is growth of the vestibular spine that is key to separating the normal atrioventricular junctions. And we can see what's happened if we look down on the atrioventricular canal in another of Wout and Jill's reconstructions, showing the situation at Carnegie stage 18. Again, the yellow is the atrioventricular canal myocardium, and you can now look down through the right orifice into the cavity of the right ventricle. You see that the atrioventricular cushions have now fused one to the other, and note that the line of fusion is pointing towards the muscular ventricular septum. So there is the vestibular spine, and it is binding together the center of the atrioventricular canal, separating it into right and left orifices. Now we have to move back one stage, because at this early stage, and now I'm back in the mouse heart, the outflow cushions are fusing together, and they are building a roof, building a shelf in the roof of the right ventricle, so as to commit the aortic root into the left ventricle, even though it is positioned above the cavity of the right ventricle. So by fusing together the cushions in the roof of the right ventricle, the embryo is tunneling the aortic root through the secondary interventricular foramen to the cavity of the left ventricle, and turning the secondary foramen, as we have discussed, into the left ventricular outflow tract. We know exactly the same thing is going on in the human embryo. So here in the human embryo, and you see we're now well into the 7th week of development. The pulmonary root is positioned cranial, arising from the right ventricle, but there is that tunnel that the embryo has created in the roof of the right ventricle, committing the aortic root into the left ventricle and closing off the tertiary interventricular foramen by fusing together those tubercles of the atrioventricular cushions. But if we look at what's going on in the situation in the human embryo at this stage in Wout and Jill's reconstructions, and I'm showing it to you as it is seen from the front, you see that although the aortic root is connected to the left ventricle by the formation of a shelf in the roof of the right ventricle, it remains aligned with the right ventricle. It's been separated from the right ventricle by the fusion of the membranous septum, the formation of the membranous septum by fusion of those tubercles. And it is that process that is remodeling the secondary ventricular intercommunication to become the left ventricular outflow tract. So if I show you the situation at this stage, Carnegie stage 23, the end of the 7th week of development, we see that there are separate atrioventricular junctions, but if you look at the myocardium of the atrioventricular canal, you see that it's still forming a relatively common entity. There in the middle, however, is the vestibular spine, and the vestibular spine is binding together the superior and inferior margins of the developing atrioventricular canal. Because at this stage, the aorta has yet to wedge itself between the developing mitral valve so as to reach its definitive position as the outflow tract of the left ventricle. So the atrioventricular canal myocardium is still relatively common. And you note that as yet, the mitral valve has not developed its extensive neural leaflet. The tricuspid valve has yet to develop its inferior leaflet. So much more has to go on subsequent to closure of the tertiary interventricular foramen. And it is that remodeling that happens subsequent to closure of the tertiary foramen that produces the definitive arrangement. So what happens? Because the vestibular spine has bound together that center part of the junction, the two atrioventricular junctions themselves are able to expand, and that produces what we call the inferior pyramidal space. And then, because the vestibular spine has bound together the center point of the junction, the aortic root is then able to insinuate itself between the developing mitral valve, and that produces another space within the cavity, the left ventricle, and we call that the inferoseptal recess. And after all this has taken place, then the membranous septum interposes itself between the aortic outflow tract and the cavities on the right side of the heart, and only then does the delamination of the septal leaflet, tricuspid valve, separate that membranous septum into its interventricular and atrioventricular components. So now Diane, in a series of dissections, is going to show you all these processes and illustrate to you what they produce in the normal heart. So she's going to show you the inferior pyramidal space, the inferoseptal recess, the membranous septum, and she's going to emphasize how the vestibular spine produces the buttress of the atrial septum, which is the true second atrial septum, and how that is undermined by the inferoseptal recess of the left ventricular outflow tract. All of this will be important as we then discuss atrioventricular septal defects.
This is a 4-chamber cut showing the right and left atrioventricular junctions, and it is immediately inferior to where the aortic root would interpose between the mitral valve and the muscular ventricular septum. The anterior inferior muscular buttress is formed by muscularization of the vestibular spine, and this is the septum of the atrioventricular canal, and it ensures that there are separate right and left atrioventricular junctions, so that this anterior inferior muscular buttress is the true atrial septum, the first being the flat valve at the floor of the oval fossa, or the primary septum, and you can see where its limbs are attached to the inferior muscular buttress, and the superior interatrial fold, which is not a true septum. This is a fold that interposes between where the superior caval vein would enter the roof of the right atrium and the pulmonary veins enter the left atrium. Looking a bit closer at this four-chamber plane, we see the normal offset of the atrioventricular valves, and here only the atrioventricular component of the membranous septum is in view. The atrioventricular valves are normally offset so that the right atrial wall in this area overlaps the crest of the muscular ventricular septum. Looking at a quick comparison of two hearts, one with an intact septum and one with a common atrioventricular junction. Here we see the normal inferior muscular buttress, which is formed by muscularization of the vestibular spine, and this ensures that there are separate atrioventricular junctions, so that this is the septum of the AV canal. Looking at the specimen with a common atrioventricular junction, here we see the leading edge of the atrial septum, so that failure of muscularization of the vestibular spine has left this heart with a common atrioventricular junction and an atrioventricular septal defect. The upper portion of the atrial septum, or the primary portion, is fairly well formed with a small defect, and you can see the flap valve adherent to the superior interatrial fold in this area. This specimen is cut a bit more anterior than the last specimen we looked at, so that we can see the aorta wedged between the two atrioventricular valves. The coronary sinus is here in the right atrium. This fibrofatty tissue plane is the space called the transverse sinus between the anterior atrial walls and the aorta. And this cut also shows us nicely how the aorta interposes between the mitral valve and the interventricular septum. So this is the muscular interventricular septum. Going in a little closer, we can see the components of the membranous septum, which are crossed by the hinge line of the tricuspid valve. So the interventricular component is here, and the atrioventricular component lies here. So this atrioventricular component of the membranous septum is the only atrioventricular septal structure found in hearts with two separate atrioventricular junctions. If I rotate the specimen just a bit, we can see that anterior inferior muscular buttress, and there is the floor of the oval fossa, or the flap valve. This muscular buttress is at the apex of the inferior pyramidal space, and you can see I have a probe in that fibrofatty plane that marks the inferior pyramidal space. We'll take a quick look at a normal right atrioventricular junction, and here is the flap valve at the floor of the oval fossa, the coronary sinus, and the hinge point of the tricuspid valve. This is to show you where the inferior pyramidal space will be located, right in this area. It will be a continuation of the fatty tissue that extends inward from the inferior atrioventricular groove. The atrioventricular node artery also runs in this fibrofatty plane and will supply the conduction axis at the apex of the triangle of Koch, which we can see nicely here. There's our tendon of Todaro and the hinge point of the tricuspid valve. And you can almost appreciate that fibrofatty plane through this very thin layer of atrial myocardium. The next specimen I have dissected to show you the inferior pyramidal space, so that the interatrial folds have been dissected away, and we have the true components of the atrial septum remaining, namely the flap valve at the floor of the oval fossa, its anterior inferior muscular rim, and the anterior inferior muscular buttress, or the second component of the true atrial septum. So this is the component that has been muscularized by the vestibular spine, separating the heart into two complete atrioventricular junctions. So here's the coronary sinus. You can see where the tendon of Todaro was running and the hinge point of the tricuspid valve. I have the atrial myocardium removed in this space so that the fibrofatty plane extending in from the inferior atrioventricular groove can easily be appreciated, and within this fibrofatty plane will be the artery to the atrioventricular node. I'm showing you this dissection to get a better feel for the position of the inferior pyramidal space. We're looking at a short axis view from the base, so we can see the tricuspid valve, the mitral valve, and the aortic valve, and how the aorta is deeply wedged between the two atrioventricular valves. The non-coronary aortic sinus and valvar leaflet have been removed, and this even accentuates the deeply wedged position of the aortic root between the atrioventricular valves. When we look a little closer at the inferior pyramidal space, the fat from the inferior atrioventricular groove infiltrates into the inferior pyramidal space, and this area interposes between the atrial muscular layer and the crest of the muscular ventricular septum, which lies deep to this fat. You can see the artery to the atrioventricular node extending from the distal right coronary artery towards the apex of the triangle of Koch. And if I tilt the specimen just a bit, there is the interventricular component of the membranous septum. The tricuspid valve hinge point would cross the membranous septum, dividing it into interventricular and atrioventricular components, of which we're just seeing the cut edge secondary to the dissection. We're going to show you the position of the inferoseptal recess by first looking at the outflow tract from the left ventricle in a normal heart. So here is the position of the inferoseptal recess. And once the aorta is incorporated into the left ventricle, the inferoseptal recess is formed. And it positions the membranous septum, which is this area here, between the subaortic outflow tract and the cavity of the right atrium. And we all remember that the membranous septum lies beneath the interleaflet triangle that's between the non-coronary and the right coronary aortic leaflets. So there is the membranous septum, and its atrioventricular component will be along the inferior-most aspect. I have a special dissection that shows us roughly a 4-chamber cut and how the aorta is deeply wedged between the tricuspid and the mitral valves. It also lifts the mitral valve away from the septum. The inferoseptal recess is just in this area, and you can see how the membranous septum is between the subaortic outflow tract and the cavity of the right atrium. So the membranous septum is nearly appearing in this cut. If we go a little closer, there is the crest of the muscular ventricular septum and some of the tricuspid valve that is beginning to cross the area of the membranous septum that we are nearly cut into the portion that is the interventricular component. So that when the aorta is incorporated into the left ventricle, the atrioventricular component, which is just deep to this cut, lies between the subaortic outflow tract and the cavity of the right atrium. I'm going to show you another dissection that I've done to demonstrate the inferoseptal recess. So what I've done is dissected around the true component of the atrial septum, or the oval fossa, the primary component, and I've virtually bisected the inferior muscular buttress. So this is the anterior portion of the ventricular septum, and I am going to lift that away from the left ventricle, the posterior-most part of the left ventricle. So we can see the aorta that's lifting the mitral valve away from the interventricular septum. There's the oval fossa, and here is the inferior muscular buttress. The coronary sinus is here, and you can see the fat coming into the inferior pyramidal space from the inferior atrioventricular groove. The area of attachment of the mitral valve to the atrial septum, you can see, runs along a very short length, and it does attach in that area where the inferior muscular buttress is located. If we look at the opposite aspect of the same specimen, it's virtually in a long axis cut, so we can see the pulmonary outflow tract here, the aortic root, and the mitral valve has been removed. So the oval fossa would be in this area. Here is the coronary sinus, and you can see all of that fat from the inferior pyramidal space. There's a little bit of the muscle left from the anterior inferior muscular buttress, and you can see how that's related to the inferoseptal recess. Looking a little closer, we can see how when that inferoseptal recess is formed, the aorta is incorporated into the left ventricle and positions the membranous septum between the subaortic outflow tract and the cavity of the right atrium, which would be just behind here. So this is a small remnant of the anterior leaflet of the mitral valve, and you can see that inferoseptal recess separating the membranous septum, which I'm pushing on the atrioventricular component, from the left ventricular outflow tract. So this would be the atrioventricular component of the membranous septum.
Having seen those beautiful dissections made by Diane, you'll now know that the only true atrioventricular septal structure we find in the normal heart is the membranous component of the atrioventricular component of the membranous septum. And now we get to atrioventricular septal defects, because on occasion, that atrioventricular component of the membranous septum can itself be deficient. And that is what we call the Gabodi defect. Specifically, it is the direct Gabodi defect. I have to show you a picture of this because I've never seen one of these. My very good friend and colleague, Carl Backer, when he was working at Lurie Children's Hospital in Chicago, found a series of these, and he has probably seen more of these than anybody else. And he was able to show by insufflating the tricuspid valve and showing it to be intact that the shunting was passing directly from the subaortic outflow tract into the right atrium. So the essence of the direct Gabodi defect is indeed that it is a deficiency at the site, the atrioventricular component of the membranous septum. So the key to its understanding is that there are separate atrioventricular junctions. So very rarely you can have an atrioventricular septal defect, a true atrioventricular septal defect, with separate atrioventricular junctions, and the remainder of the septal structures are intact. Now, we also then have to remember that it's also possible to have atrioventricular shunting through a ventricular septal defect. And that occurs when we have a deficiency at ventricular level, but there is an accompanying deficiency in the leaflets of the tricuspid valve, permitting the ventricular shunting to come up to and pass into the right ventricle. And this is what is known as the indirect Gabodi defect. And this is the common variant when there are separate atrioventricular junctions. So again, I am showing you a picture. We don't have a heart to illustrate this lesion to you, but it is more frequent than is the direct Bode defect. The key, there are separate atrioventricular junctions. So in essence, this is no more than a perimembranous ventricular septal defect that shunts at ventricular level, but then the ventricular shunting comes up through deficiency in the leaflets of the tricuspid valve and enters the right atrium. So there it is, a left ventricular to right atrial shunt, which is an indirect Bode defect. But what now we're going to move on to is to look at atrioventricular shunting in the setting of a common atrioventricular junction. Because you all know that nowadays, when we talk about atrioventricular septal defect, this is what we mean. The phenotypic feature is the common atrioventricular junction. Well, what I'm going to show you is that the underlying problem is a failure of the vestibular spine to anchor together the center point of the developing atrioventricular junction. And I can tell you this with a degree of certainty because now, amongst our data sets of mice hearts, we thought these were normal mice hearts, but amongst these allegedly normal mice hearts, we found 4 examples of atrioventricular septal defect with common atrioventricular junction. So now I can show you what is going on in these mice hearts with these 3-dimensional data sets. So you'll immediately recognize here I'm showing you a 4-chamber cut through such a mouse heart, and it's just prior to the stage at which this mouse should have been born. So there you see the primary septum. It's dividing the right and left atrial chambers. And the important point, on its leading edge, you see that the mesenchymal tissue has muscularized. So this is the muscularized mesenchymal cap, and it's almost down to the level of the atrioventricular junctions. But there is a gap in the middle of the heart, and there is a common atrioventricular junction. So this is an atrioventricular septal defect with common atrioventricular junction. And the bit that is missing is the vestibular spine. The vestibular spine has not grown forward and has not bound together the center point of those junctions. So this is the same data set. I simply cut it so that you can look down on the atrioventricular junction from the atrial aspect. So the left side is now to your left hand, the right side to your right hand. And immediately you will see the commonality of the atrioventricular junction, the unwedging of the left ventricular outflow tract. But the cushions themselves have fused. So the fusion of the cushions within this common atrioventricular junction has separated the cavities into right and left orifices. And this is a key point to understand what is going on with atrioventricular septal defect with common atrioventricular junction. Because there is a common atrioventricular junction, however, the developing leaflets of the left side have retained their trifoliate configuration. And you see that part of that trifoliate configuration is between the 2 leaflets that are the left ventricular components of those cushions that bridge the ventricular septum. This is another of the hearts that we found with an atrioventricular septal defect in otherwise wild-type mice. So there you see the left ventricular component, the superior bridging leaflet. There is the left ventricular component of the inferior bridging leaflet, the developing leaflets, because at this stage, they're still almost cushion-like. And now you see that the space between them is a zone of apposition. This is what for many years was called the cleft. Nowadays, we put the cleft in inverted commas because we know that it's not really a cleft at all. It is the zone of apposition between those components of the cushions that retain their position within the left ventricle. In this mouse, however, you see the inferior cushion is firmly bound down to the crest of the septum, as is the superior cushion. And additionally, as we've also seen, the cushions are fused to each other. But the aortic root is unwedged. The primary atrial septum is nearly down to the level of the atrioventricular junction, but the thing that is missing is the vestibular spine. There has been no growth of the vestibular spine to bind together the center point of the developing atrioventricular canal. And another feature that follows from that is that there is inlet-outlet septal disproportion. So, because the vestibular spine has not bound together and anchored the center of the canal itself has been able to expand, so giving us the common atrioventricular junction. The lack of that anchorage has prevented the aortic root from insinuating itself between what would become the mitral valve, the septum, and it has produced that disproportion between the inlet and outlet parts of the muscular ventricular septum. And Diane now is going to show you a series of hearts with atrioventricular septal defect, common atrioventricular junction with a common atrioventricular valve, and she's going to illustrate all of these phenotypic features, which all flow because the vestibular spine has not bound together the center part of the atrioventricular junction.
This four-chamber view will show us the so-called complete type of atrioventricular septal defect. We have concordant atrioventricular connections with a common atrioventricular junction. The leading edge of the atrial septum is here, so this is the atrial component of the atrioventricular septal defect, and this is the area where the vestibular spine failed to muscularize and separate the right and left atrioventricular junctions into two separate junctions. So in this case, we have a common atrioventricular junction with a common atrioventricular valve. The upper portion, or the primary portion of the atrial septum, is fairly well formed with a small defect at the floor of the oval fossa. This is the crest of the muscular ventricular septum, and you can see the inferior bridging leaflet crossing it with multiple tendinous cords attaching it to the septum. So it is a bit tethered in this particular case, but there is still the availability of blood to go beneath that inferior bridging leaflet. Looking at the opposite aspect of the same heart, so we're looking from the spine towards the sternum. Here's the right atrium, the left atrium, and again our common atrioventricular junction. This little scooped out area is the anterior-most aspect of the oval fossa, and here is the area where the vestibular spine failed to muscularize. So this is the atrial component of the atrioventricular septal defect. The superior bridging leaflet is free floating over the crest of the muscular ventricular septum, and you can see how the septum is scooped out in this case. This is a normal heart, looking at it on short axis from the base, so that we can see the tricuspid valve guarding the right atrioventricular junction, the mitral valve guarding the left atrioventricular junction, and the aorta, which is deeply wedged between the two atrioventricular valves. Muscularization of the vestibular spine allowed for two separate atrioventricular junctions in this case, and for the aorta to incorporate normally into the left ventricle. A heart with a common atrioventricular junction has had failure of that vestibular spine to muscularize, so that we end up with a common atrioventricular junction. And incidentally, in this specimen, the patient had right atrial isomerism with pectinate muscles around both the right and left components of this common junction and extending to the crooks of the heart. The aorta is clearly unwedged, as it was not allowed to be incorporated normally into the left ventricle, secondary to the common atrioventricular junction. If we look at this common atrioventricular valve, it is quite dysplastic, but because of that, it shows the valvar leaflets quite nicely. So there is the superior bridging leaflet, the inferior bridging leaflet, which are not adherent to one another across the crest of the septum. There is the anterior superior leaflet and the inferior or mural leaflet within the right ventricle, or in the right component of the common AV valve. The left component is made up of the left half of the bridging leaflets along with this mural leaflet. And you can see how the left atrioventricular valve has a trifoliate zone of apposition. We're looking at a long axis cut of a normal heart, and we see the left atrium with the coronary sinus at the left atrioventricular groove. Here's the mitral valve and the aortic valve. And what I want to point out to you is that the inlet-outlet dimensions are virtually equal in the normal heart. So here is the inferior most hinge point of the mitral valve. If we measure that to the apex and compare it with the measurement from the apex to the aortic valve, they are virtually equal in the normal heart. When we see hearts with atrioventricular septal defects, these inlet-outlet measurements are disproportionate, and that is dependent as well on the degree of scooping out of the interventricular septum. The inferior hinge point within the left ventricle of this inferior bridging leaflet to the apex is clearly shorter than the measurement from the apex to the aortic valve. So instead of being relatively at the same level, they are at quite an angle with one another. So inlet-outlet septal disproportion.
So what we have seen is that if the vestibular spine does not anchor together the center point of the junction, then the junction itself is able to expand and gives us the phenotypic feature, the commonality of the atrioventricular junction. But what you've already seen in those mice hearts is, even though there is a common atrioventricular junction, the cushions themselves can still fuse to produce separate orifices for the right and left ventricles. And that is exactly what we see in the heart that we call the ostium primum defect. It has all those phenotypic features that you've just seen in the heart with common atrioventricular valvar orifice. And now Diane is going to show you how those same features can be found in the so-called ostium primum defect, which is no more than an atrioventricular septal defect with common atrioventricular junction, but with separate valvar orifices for the right and left ventricles.
Here we have a heart with a common atrioventricular junction, and this is the so-called primum ASD, or atrial septal defect, when in reality it is not an atrial septal defect at all. It is the atrial component of a common atrioventricular valve or atrioventricular septal defect. The oval fossa is fairly well formed with a few fenestrations in the flap valve, so a very well formed primary portion of the atrial septum, and there's the coronary sinus. This area is where the vestibular spine failed to muscularize, and you can see in this particular heart nicely that if this area would have muscularized, there would have been two separate atrioventricular junctions, and the aorta would have been able to normally wedge itself into the left ventricle. This portion is deficient in this specimen, so there is a common atrioventricular junction, And if I tilt this up, this common atrioventricular junction has two separate orifices, a right orifice and a left orifice, which we'll look at in a moment. The superior bridging leaflet and the inferior bridging leaflet are attached to one another across the crest of the septum, effectively separating this common atrioventricular junction into right and left components. Looking at the left component of this common atrioventricular valve, here we see the leading edge of the atrial septum and the flap valve that's fenestrated at the floor of the oval fossa. The bridging leaflets, again, you can see are adherent to one another across the crest of the septum, with the zone of apposition, or what some people call the cleft, pointing directly at the interventricular septum. Even though there are separate orifices in this heart, there is still a degree of scooping out of the ventricular septum, and the inlet-outlet disproportion is still discrepant between the inlet and outlet components. So if we look at the hinge point of the atrioventricular valve to the apex on the inferior aspect or on the inlet, it is much shorter than that dimension on the outlet component. The aortic valve isn't opened here, but you can truly appreciate that this outlet dimension is much greater than the inlet dimension. So again, a common atrioventricular junction with separate right and left orifices that still exhibits the same features as does the so-called complete type of atrioventricular septal defect. As well, in this case, the aorta is unwedged and unable to join the left ventricle in usual fashion.
So what you've seen is that the ostium primum defect has those same phenotypic features, but as clinicians, you know there are fundamental differences between what you call the partial defect, many of you call the complete defect, even though the phenotypic features are much the same. So what is it that produces the difference? The major difference is the potential for shunting across that atrioventricular septal defect. And that shunting can be exclusively at atrial level, as in the ostium primum defect. Much more usually, there's the potential for shunting at both atrial and ventricular levels. And that's what most of you will call the complete defect. Much more rarely, the shunting can be confined at ventricular level. So now we're going to show you what happens. And it all depends on what happens with the bridging leaflets of the atrioventricular valve relative to the septal components. So in the so-called complete defect, the bridging leaflets float. So there's the potential for shunting at atrial level and ventricular level. But if you take those bridging leaflets and you attach them to the leading edge of the ventricular septum, then that will confine shunting at atrial level. If, however, you take the bridging leaflets and you attach them to the undersurface of the atrial septum, then shunting will be confined at ventricular level. And Diane very shortly is going to show you precisely that in a given heart by moving the bridging leaflets. We don't have a heart to show you, but you must also remember that on rare occasions, those bridging leaflets confuse in such a way to take away the potential for shunting. So we know that on rare occasions, you can find individuals that have what was initially an atrioventricular septal defect, common atrioventricular junction, but the defect has closed spontaneously. But at this stage, we're going to look at a heart with a defect, and Diane is going to demonstrate the influence of the relationship between the bridging leaflets and the septal structures.
We're looking at a so-called complete type of atrioventricular septal defect, and the potential for shunting will be dependent on the relationship of the bridging leaflets and the septal structures. In this particular specimen, the atrial component of the defect is here, and the scooped out portion of the ventricular septum there, with the superior bridging leaflet free floating over that septal crest and tethering to some extent of the inferior bridging leaflet to the septal crest. But you can still place a probe beneath that leaflet. So in this particular specimen, there is shunting of blood at both the atrial and the ventricular levels. When we have a so-called primum type of atrioventricular septal defect, we have separate right and separate left orifices, as we previously saw, so that the superior bridging leaflet and the inferior bridging leaflet are attached to one another across the crest of the septum and attached to the crest of the septum itself, so that no blood can pass on the ventricular aspect of this valve. So that in this case, there is only shunting permitted at the atrial level. The remaining specimen is a quite rare specimen to find, and this is the best example that I have, but I think it will illustrate the point. The atrial septum is well formed. The oval fossa is there with the flap valve, and the leading edge of the atrial septum, where the vestibular spine failed to muscularize, is in this area. There's the coronary sinus. And what I want you to appreciate is that the bridging leaflets have more of an affinity for the leading edge of the atrial septum than they do the crest of the ventricular septum. So that when these valvar leaflets close, they abut against that leading edge of the atrial septum, and there is only ventricular shunting allowed. So again, the potential for shunting is related to the relationship of these bridging leaflets to the septal components.
So what Diane has shown you is that you can on occasion have atrioventricular septal defects, common atrioventricular junction, in which the shunting is exclusively at ventricular level. But over recent weeks, you've also seen on several occasions a heart which some would still describe as having a ventricular septal defect of atrioventricular canal type. And that is the heart that has straddling and overriding of the tricuspid valve. You'll remember we looked at that heart last week and we've seen it several times. But does that heart have an atrioventricular canal? And the answer, of course, is that it doesn't, because the feature, straddling and overriding of the tricuspid valve, is the fact. Tricuspid valve straddles and overrides also in presence of a mitral valve. So these hearts do not have AV canal defects. They have perimembranous defects that are characterized by atrioventricular septal malalignment. So Diane is now going to show you that heart again to emphasize that there is no common atrioventricular junction, because it is the commonality of the atrioventricular junction that is the essence of what we are talking about today, atrioventricular septal defect.
Looking into the right atrial chamber, we see that there is a morphologically right atrial appendage. The flap valve at the floor of the oval fossa is intact, and there is the coronary sinus. We can see a well-formed right atrioventricular junction. And if we tilt the heart on its apex and look into that junction, there is the crest of the interventricular septum. If you initially looked at this, it could easily be confused as a common atrioventricular junction. And this is the defect that a lot of people refer to as the atrioventricular canal type of ventricular septal defect. The tricuspid valve is straddling and overriding the crest of the ventricular septum. And when we look at the left atrium, we see a well-formed left atrioventricular junction. The atrial septum shows us the flat valve with its horns normally attached to the superior interatrial fold, and the smooth vestibule of the left atrium. So there are separate right and left atrioventricular junctions in this heart with straddling and overriding of the tricuspid valve. The second component of the true atrial septum, or the inferior muscular buttress, has normally formed in this heart, and this is the septum of the AV canal. Muscularization of the vestibular spine ensures that we have separate atrioventricular junctions. In this case, there is straddling and overriding of the interventricular septum across the crest of the septum, so there is an interventricular communication or a ventricular septal defect, but two separate orifices and not a common atrioventricular junction. We have our left atrioventricular valve from the left atrioventricular junction and the right atrioventricular valve straddling and overriding the crest of the interventricular septum, but with its own atrioventricular junction.
So if I summarize everything, it all comes down to one key question. Is there a septum of the atrioventricular canal? And I hope we've shown you that there is such a septum. It is the vestibular spine, because it is the vestibular spine that anchors together the center point of the developing atrioventricular junctions, preventing the formation of common atrioventricular junction. It forms, however, the buttress of the atrial septum, and it is that muscularized vestibular spine that is the true second atrial septum. There is no atrioventricular septum within the ventricular component of the heart, but it is the presence and normal formation of the vestibular spine that ensures the presence of separate atrioventricular junctions. And then very rarely, the atrioventricular component of the membranous septum itself can be deficient to give us the direct Gabodi defect. But what I hope we have shown you is that the key player in the formation of atrioventricular septal defect with common atrioventricular junction, by far the commonest variant of atrioventricular septal defect, is failure of formation of that player, which is the vestibular spine. So all devolves on whether the vestibular spine grows forward, anchors together the center point of the developing junctions, and prevents the ongoing formation of that common atrioventricular junction.
Thank you very much for that, Dr. Anderson. And Dr. Diane, it was very good. So we are going to start. Guys, please type your questions on the Q&A chat box. In this meanwhile, I want Dr. Norman Silberman, if he could please make his comments. And after that, Dr. Adrian has some hearts surgical hearts to show us. So I think this is going to be very, very interesting. But I really like to see the comments of Dr. Silverman, and if the other panelists has comments as well, for us to start with, and then we are going to move forward to the surgical hearts.
Thank you very much. I mean, it was so clear that there really are very few questions. I could just say as an echocardiographer that the examples that I have seen of the isolated ventricular component, the atrial septum is usually fused to the atrioventricular junction, and it's there is almost always a so-called cleft in the mitral valve as the key point. The other interesting issue is, if I look at my series, and I've seen about 16 of these hearts in my career, so they're not common, and perhaps that's why we only have one specimen. But they almost always have been associated with Down syndrome with the trisomy 21. And I don't know whether you have any recollection of that in your specimens. But Bob, what I wanted to ask you with regard to that is, when looking at the mice embryo, we have noted that there are mice models for Down syndrome. And I wonder whether the stuff you have of the episcopic microscopy comes from Down syndrome mice.
No, in fact, the mice that we have found, the 4 that we found, were part of the overall series that Dr. Mohan prepared of allegedly wild type mice. They're black. There's a particular strain that he uses, but he has done some work also with a group at the Crick Institute, and they do have other mice that, as you say, are of the Downs. So they're mosaic mice. And the interesting thing in those, in fact, is that some of them can have formation of the vestibular spine and yet still have an atrioventricular septal defect. So the entire story is not with the vestibular spine, but in those wild type mice, unequivocally, it is the vestibular spine that is lacking. And in humans also, all the evidence is pointing to the fact that it's failure of formation of the vestibular spine that fails to bind together that second part of the junction. But they have, the group at the Crick Institute have also done work with the mice, as you say, the Downs type mice. But the hearts I showed, those 4 hearts, were all wild type mice, and we came across that as a chance finding. It was a chance finding amongst the 400 and odd data sets that we've been looking at, and we were very surprised to look into the data set and find a common atrioventricular junction, all the features that you expect, and they were ostium primum type defects. So they had separate orifices for the right and left ventricles.
Yeah, and as I talked about that, the cleft is really almost always pointing towards the muscular septum, as it is in an AV septal defect in these particular examples.
Well, indeed it is, because they are atrioventricular septal defects. And you remember, I mean, a long time ago when you came to Pittsburgh, we looked at the difference between the true cleft, and you can have a true cleft in a proper mitral valve with the aorta wedged between it, and then the cleft points it towards the aortic outflow tract, whereas what we are calling the cleft is the zone of apposition between the left ventricular components of the bridging leaflets, and we shouldn't really be calling it a cleft at all. You're slipping into your old bad habits.
No, I'm not doing that, but I think there's a clinical point that's important here, that when you see, as a clinician, an echocardiographer, a perimembranous, so-called perimembranous VSD, and there also is a zone of apposition deficiency, but let's call it a cleft in inverted commas for this point of view in time, and it points towards the muscular septum. That really what you're dealing with is the isolated ventricular form of the AV septal defect. And what's important for that is for the surgeon, and perhaps Adrian and Sasha can comment on that, because the approach to fixing that is going to be a lot more difficult than if you think of it as a perimembranous VSD, particularly if you're going to do something on the so-called cleft in the valve, because basically you have to open the atrial septum to fix the cleft properly. So that's the point that I wanted to make about this.
No, you make a very good point there, because you will remember that you can also have isolated clefts with a proper mitral valve with a perimembranous ventricular septal defect. And you'll remember we looked at those in the Pittsburgh archive. And I think you subsequently followed up with that, and you wrote an echo paper using your experience whilst you were still at UCSF, did you not?
Yes, I did. And we looked at the fact that the cleft, the so-called cleft, as we looked at it, was totally different in the isolated VSD as opposed to the isolated form of an AV septal defect. So perimembranous for AV septal defect, the cleft was in a different position. And not only was the cleft in the different position, Bob, but you will recall that the papillary muscles are also, you see, we don't have the ability to look at the junction as clearly as you do when you look at a morphological specimen. So what we're really looking at is the other features of an AV septal defect. And of course, we know that in a AV septal defect, the anterior leaflet or the aortic leaflet occupies a much larger portion of the circumference than the mural leaflet. And when the mural leaflet is small, the papillary muscles become close together, and they can become so close that they become a single papillary muscle. So that's very important in looking at the difference in these patients. And when you see the papillary muscles very close together, then you must really also consider that this is an AV septal defect.
Indeed. Indeed, and nowadays, of course, you can see there's so much better with three-dimensional echocardiography or with computed tomography or magnetic resonance imaging. And that point would be particularly important in three-dimensional imaging.
Yes.
So before we move forward to the questions, I think we could let Adrian to show the hearts that he selected for us today.
Sure. I hope you can all hear me. Thank you again for the invitation. I will be very brief, but I will touch on a few of the issues that Dr. Silverman and Professor Anderson raised. And I'll start with this heart. If we are looking at the heart in attitudinally correct position, so here it will be the right ventricle, but I will move quickly to open the right atrium. As you can see here, it is very difficult to distinguish this tissue from the rest of the tissue, but this is actually a patch of autologous pericardium that was used to close the interatrial component of this atrioventricular septal defect. You can see some remnants of past sutures. And the idea behind this, I'm looking now from the left side, you can see again that there is a small residual defect that was left here between the patch of autologous pericardium and the native structure of the atrial septum here. And again, if I look at in the left atrium from above, you can see the sutures, and I will zoom in more. You can see the sutures that were used to close the zone of apposition between this superior bridging leaflet and the inferior bridging leaflet, which now torn. But these were the suture used to close this zone of apposition. And it's clear that the zone of apposition will aim towards the interventricular septum. Of course, as surgeons, we cannot create a vestibular spine. We cannot recreate two junctions. We cannot unwedge the aorta. What we can do is just to divide the atrioventricular valve. And here is a heart that is a heart and lung block. And again, this is the right ventricle. I will move quickly towards the right atrium and I will open the right atrium. You can clearly see now what happens on the septum, a patch was used to actually close the atrial component of the septum. And if I look from the other side, I will see that in the left ventricle, there is actually a cage, a ball in a cage valve that was used to replace the left atrioventricular valve. More importantly, the effect of this valve, replacement of the left atrioventricular valve in some of these patients, will create an impingement towards the left ventricular outflow tract. This is the aorta. As you remember, this is an unwedged aorta, and look at the valve. If I try to close this heart, you'll see how narrow this left ventricular outflow tract will be for this aorta. And if I move to just another heart, again, this is a heart that you recognize in attitudinally correct position with the right ventricle. Here, I rotate the heart to enter it through the right atrium. And here, when I open the right atrium, you'll see again a patch of Dacron that has been used to close that defect in the atrioventricular septum. And if I look from the left side, you'll see again the patch, but you'll also see the two leaflets, superior and inferior bridging leaflet. And I'll zoom closer to show you how the zone of apposition in this case was closed between the two leaflets. Now again, this is inferior bridging leaflet, this is superior bridging leaflet. These are the sutures used to close the zone of apposition between the two leaflets. And of course, this is a Dacron patch seen from the left side. In this case, there is a papillary muscle here, and there is a papillary muscle here. And if I look from above, there is a very good sized mural leaflet. So there is a good sized mural leaflet, superior bridging leaflet, inferior bridging leaflet. And if I open in the left ventricular outflow tract, you can see now how capacious this left ventricular outflow tract is. This is the superior bridging leaflet in continuity with the aortic leaflets, but it is a very capacious. And again, I'm showing you where that closure of the zone of apposition is. It is here, and it aims towards the ventricular septum. And just to show you another heart, in this case, again, this is a replacement, the left AV valve. I'm looking at this heart from the left ventricle. You see it's a tilting disc valve, which again compromises quite a lot the left ventricular outflow tract. If you see where the aorta is here, and what's the space between this impingement of the replacement of the valve and what happens under the aortic outflow, it's very tight space. One thing that I'll show you is from above. This is what happens in the left atrium. To recognize the left atrial line that we live in these cases to understand what happens with the hemodynamics in these cases. And probably one more heart, if possible. I'll open it again from right atrium. This is a large interatrial patch. It's a Dacron patch, as you can see here. If I look in this heart from the left side and I try to open, please take note of this small space in the left atrium. It is not rare to actually have very little space when we try to work into that atrium. And remember, the way we work in these hearts is through the right atrium, so we don't have the luxury to open the left atrium in this case. And again, it is another replacement that was required of the left AV valve. I'm sure we'll discuss about the percentage of patients that end up like this. You can see here the patch that is below this valve. So it would be at the interventricular level in this case. And the valve was anchored onto this patch as to replace the rest of the compromised AV valve. Thank you very much.
Adrian, those were beautiful presentations. Grace, I see we have Dr. Quinticenza available at All Children's Hospital. He was there a moment ago. Can we ask, is he there? Is Diane with Dr. Quinticenza?
Yes, hi,
This is
Bob.
so nice.
Q, well, let's have your thoughts about Diane's beautiful presentations.
No, they were exquisite. I think, we've seen in more detail than ever before the morphology of this. And I liked Norm's comment last week that the human brain is only capable of a certain percentage of this lecture. And I think it's, again, the case. But I think the specimens are great. And I think the ability to understand and really see this as we go into the operating room, it really enhances, what we see sometimes. I did have a question, if I could, about transitional AV septal defects. And we haven't really mentioned that word, but oftentimes we'll see shunting, especially from our echo colleagues, where they're shunting below the plane of the AV valve leaflets. But when we get in there, there is really no separate ventricular communication other than it's like the zone of apposition of the left side of the AV valve has a little gap, and the shunting occurs below the plane of the AV valve as well as above as an atrial communication. And we just simply close the entire zone of apposition and all shunting goes away. And I think there's always confusion about this transitional or ventricular level shunting with primarily a partial AV septal defect.
Well, the problem, as you say, is the term in itself, because what you're describing is the situation in which the bridging leaflets are effectively bound down to the crest of the septum, and yet there is a small gap between them. So essentially, you still have a common junction with that small bit of bare septal crest that, as you say, you can obliterate when you close the zone of apposition. And interestingly, that was the type of defect that was initially called the transitional type by Wackeye and Edwards a long time ago now. But more frequently, people have called the transitional types the type where you have the ostium primum defect, and yet there is intercaudal shunting between the defects and the septal crest. And that's why I do not like the term transitional or intermediate at all. I think we should describe whether the bridging leaflets are joined together and whether there is shunting underneath the inferior or the superior bridging leaflet. But that is, the situation you describe is one of those variants.
Yes, it becomes quite difficult echocardiographically to differentiate that. But I think you can see very easily with echocardiography, the interventricular shunting. So, but the transitional is a difficult word for us because if they're shunting below, they're shunting below, and the surgeon has to take care of that. Or maybe if it's very small, it may be expedient to leave small interventricular communications. Maybe Jim or Sasha could say something about that. Is it necessary to go in, try and fix all of these lesions and get in underneath the AV valve leaflets to put in a small patch to save a complete repair?
Well, I would just say that I think we can find these levels of shunting just by gentle probing underneath the leaflets. And sometimes it's a matter of just putting one mattress suture in there and not risking AV conduction and things like that. They don't really require a patch because they're small defects. But our goal is to get an echo perfect result, Norm, so that you come to the operating room with your 5 Ps and we're off to closing the patient. So sometimes it's physiologic.
To an extent, Q, you're touching on what now is quite popular, the so-called Australian repair, where you fold down the bridging leaflets anyway, and you use those to close the potential for ventricular shunting. Are you in favor of the Australian repair?
I mean, I think the outcome data on the Australian repair is very acceptable. I'm not particularly a fan. I think I was just trained in a different way and have had very satisfactory results. So, but for small defects along the inferior bridging leaflet, I think it's a really nice thing to do. Is just plicate that lower aspect of the bridging leaflet to the septum directly. For a big regular, complete AV septal defect, I'm a 2-patch guy.
Sasha, what do you think?
Oh, I think perfectly as Professor Quintessenza. We use the NAN. Australian is, the paper was for Professor NAN. We like this technique, but we like when the BSD is very small or when we can use the leaflet for this reason. And we prefer a double patch technique for the complete repair. Every time when you close the cleft in a very huge atrioventricular septal defect, you are scared that the closure of the cleft will make some obstruction of the outflow tract. So I'm very attracted by the heart from Adrian, because he clearly demonstrates that when you replace a left atrioventricular valve, the outflow tract is completely going to close. So is something that is better to don't face in a clinical practice.
Indeed. I mean, the interesting thing, we call it the Australian technique, but in fact, it was my old friend and colleague, Benson Wilcox from the University of North Carolina, who did it for the first time. So, but we're happy to call it the Australian technique. And Graham Nunn, as you say, was the major exponent of that. And he always folded over the leaflet rather than displacing it. So he took great care not to obstruct the left ventricular outflow tract, because you're right, that is one of the potential problems when, if you think of just folding down the leaflet.
I would just show you this heart, because look at the level of scooping. I mean, the left ventricle here, this is the aorta, and this is the superior bridging leaflet, inferior bridging leaflet with the zone of apposition here, beautifully shown. But look at the level of scooping.
Yeah.
How one can think that can bring this superior bridging leaflet to actually come down here without producing narrowing into the left ventricular outflow tract. I mean, we have to look at the anatomy when we consider these repairs, because some of the scooping is really, really significant in these cases.
You are right, Adrian. And
Nice shunt in addition. Huh?
Yes.
Nice aortopulmonary shunt. So just one important point. I think about the NUN repair, that the appropriate term is that none should have the repair. And the reason why I say that is because of the new technology that my very good friend Jeff Smallhorn has done in terms of the tension on the valve. And we know that, in fact, that when you pull the valve down, you create all kinds of tension on the valve that we have not previously been able to determine without looking at these three-dimensional strain models of what happens to the valvular tissue. And I think this is certainly going to be the future directive of the ability of the technology to help get the most appropriate repair. And when you pull the valve leaflets down, you create all kinds of tension on the valve. And of course, the valve has to last for life. So, you know, just the fact that you get a good repair for the first couple of years of life is not essentially the problem. And certainly the work from the gentleman from Groningen, I can't remember his name now. Charles Abels, yes, showed that, in fact, that when you put sutures in a valve, eventually you can get calcification on the valve. And that indeed affects the way the valve can function in the long term as well. And that's really the issue of the AV valve on the left side.
You know, I just make one other comment. I think the goal for surgeons when they enter and they go in for an AV septal defect repair is to try to create septations and do approximation of the zone of apposition, but minimally disrupt the tension on all the structures, because it's a beautiful dynamic. When you insufflate the valve, you see how it comes together, and our goal is to get rid of the shunting, as we've talked about. That's the physiology, that's the bad physiology. We want to try to maintain as much of other normal attributes of the entire region as much as possible. So the NUN technique really distorts the anatomy in a huge way, and I think there's there is the tension issue. But surprisingly, the left ventricular outflow tract obstruction doesn't seem to come out when people, really report the larger series of the technique. So I don't know, but I'm a fan of maintaining as much normalcy as possible.
I think, to be fair, now that the proponents of the Australian technique are proposing that it not be used unless the scooped out portion of the ventricular septum is less than 0.75 centimeters. So only if it's very small are they proposing to use that technique.
That makes absolute sense. I think that's very sensible.
That's a very good point. One other issue that I'd like to raise here from the surgical point is what happens when we are faced with a single papillary muscle with a type of parachute valve, as you can see here. I'm looking at the left ventricle. This is the intraatrial patch looked through the left atrium. And if you see here, there is a very deficient valve on the superior bridging level and inferior bridging level with a very small zone of apposition to close here between them. But also there is a deficient mural leaflet that one can see here. And the entire left atrioventricular valve is supported by this single papillary muscle that is in the left ventricle. That will leave us with very little tissue here and with a lot of tension if we try to bring these leaflets together and to use the mural leaflet that is in this valve.
Well, you make a very good point there, Adrian, because of course the zone of apposition is part of the valvular orifice. And with the smaller the mural leaflet, essentially, you can end up with a bifoliate valve with just the left ventricular components of the two bridging leaflets, and then you can't close it. Because if you close the quotes cleft on that occasion, you'll create an imperfect left AV valve. So that's a particularly important point you raise.
So I'd like to direct a question to our surgical colleagues, because we know that morphologically, when you look at the left ventricular outflow tract in an AV septal defect, it's narrowed before you even begin. And that the opportunity for obstruction, as described by Bob Freedom many years ago, and rapid acceleration of left ventricular outflow tract obstruction is certainly a problem. Now, the valves that Adrian had showed us were all encroaching on the left ventricular outflow tract. They were very high-profile valves. Our approach in dealing with this, not very successfully, I might say, is to put the valve in a supraannular position. And I'd like to ask the surgeons whether they think that they can spare the left ventricular outflow tract by putting the valve in a supraannular position. Q?
Dr. James, do you want to answer that?
I would just say our approach has been, using a bileaflet tilting disc valve, not a caged valve, with such a large, component going in the LV outflow tract as number one. And number two, oftentimes just to put a size of a valve that's even reasonable size in a small baby, should that need be the case, you have to go outside the annulus and use a variety of like top hat procedures or other procedures to place the valve more in the atrium. So yes, that's what we would do. The valve choice and the position of the valve. Exactly.
Okay, very, very nice. The discussion is always amazing. I need to say that having another surgeon in the discussion is bringing a lot of new look on that. And I'm very, very glad for Congenital Heart Academy for sure that Dr. James is joining us on this webinars. Please, as much as you can, continue to join us because it's bringing a lot of information to our audience. Thank you for that.
I noticed, Grace, that we've had some questions from Dr. Troconis.
Yes, we do.
And I see he asks, are straddling tricuspid valve most frequently associated with inlet VSD, which is correct. They are, but it is not an AV canal, as we have shown. He also asks, is the so-called mitral valve cleft in an ostium primum? It is the zone of apposition between the bridging leaflets of the left AV valve. It is not a cleft. We also have a question here from Dr. Hawarasul, who brings in the vestibular defect. And there, in the buttress, we should have mentioned that in fact it is both the mesenchymal cap and the vestibular spine that come together to form the buttress. And so the vestibular ASD is failure of fusion between the vestibular spine and the mesenchymal cap, because you have the vestibular ASD, which is a proper atrial septal defect with separate atrioventricular junctions. We have Paolo Zielinski with us again, but I'm not quite sure what question Paolo is asking. I don't know whether we can get Paolo on board and he can ask it directly, or
Yeah,
I don't understand his question.
I'm sure we can. Dr. Paolo, if you click on raise your hands, we can promote you for panelist. And we have two questions from Miguel as well.
Complete AVSD and tetralogy. We'll discuss that, in fact, next week. Next week, Diane has already prepared a specimen to show the combination of atrioventricular septal defect with tetralogy of Fallot. So be a little bit patient for that one.
Very good.
Paolo, are you with us?
Yeah, I don't think he clicked on.
Okay.
Yeah.
Well, thank you very much for a great session. It was very clear today, Bob.
I thought, well, Diane's presentations are what I was particularly impressed with were the presentation she showed of the normal heart. And I'm sure many people saw things today in the normal heart that they'd never even thought of before. And her demonstration of the infraseptal recess was absolutely exquisite. And that's the nicest demonstration I've ever seen of the infraseptal recess. And also her demonstrations of the inferior pyramidal space were superb.
And it makes very easy when you have the comparison of a normal heart and then with a heart with defect. Makes much clearer to understand. Thank you for that.
Absolutely.
Paul is here. Paul is here. Paolo is here.
Paolo.
Oh, well, congratulations for another beautiful session. My question is just going back to the difference between AV septal defect and AV canal DSD, so-called AV canal DSD defect. And what I was asking is, if you have an AV canal DSD, which is always another thing than an AV septal defect, and if there is such thing, there will always be a malalignment between the atrial and the ventricular septum. And depending, of course, of the degree of overriding, you will have a double inlet left ventricle if there is the tricuspid valve, which is overriding, or a double inlet right ventricle if it is the mitral valve, which is straddling. Okay, I understand this, but can we say that if there is a common AV junction in this setting, it is an AV septal defect?
For sure, because the AV septal defect, the essential phenotypic feature is the commonality of the atrioventricular junction. So the point you make is a very good one, that always, what used to be called the AV canal defect, which was associated with straddling of the tricuspid valve, the essence of that defect, as we've now shown on multiple occasions, is the presence of the separate mitral valve with its own junction. And I agree with you 100% that the essence of that is the malalignment between the atrial septum and the ventricular septum. And it was said that this defect was due to absence of the septum of the atrioventricular canal, but we now know that that is not true, because it is the buttress of the atrial septum that is the septum of the atrioventricular canal. septum of the atrioventricular canal is an atrial structure. So we have to get rid of this notion that there can be an AV canal defect. There is either a common AV junction or else there are separate AV junctions, which in essence is what you're saying. So I agree with you in that respect.
Thank you very
So
much.
Bob, let's just see. Yeah, as I understand it, the vestibular spine is also responsible for creating the alignment of the atrial with the ventricular chambers.
No,
as
no,
well.
no. The vestibular spine can, in fact, come down and separate the AV junctions without there being septal malalignment, which is, it's an interesting point you make, that it can, in fact, grow in and can separate the AV junctions even without there being even with incomplete expansion of the atrioventricular junction, because the vestibular spine forms the buttress of the atrial septum. So, for example, in double inlet left ventricle, you have a vestibular spine. It's separated the atrioventricular junctions, but they're looking into the left ventricle. So it doesn't have to be aligned with the ventricular septum. It's a good point you make.
Thank you.
I have a very good heart for that.
Dr. Hollander has a comment.
If you look at this heart, this is a heart with atrioventricular septal defect, which also has malalignment between the interatrial septum, which you can see here, and the ventricular septum that is shown here. The atrial septum goes towards the right side of the ventricular mass, whereas the ventricular septum remains here. And as such, the inferior bridging leaflet will straddle on its own above this ventricular septal crest. Again, this is interatrial septum, which is here, going towards into the left ventricle, and this is ventricular septum.
And it's a very nice heart you show there, Adrian, because the conduction system will not go to the crux of the heart. The conduction system will come up at the point where the ventricular septum meets the atrioventricular junction.
Exactly.
Beautiful heart.
Yeah.
Very good. Okay, go ahead.
No, just to ask, Doctor, would you call this heart an AV septal defect with double inlet?
No. No, because we have to understand what happens with the valve in this case. The common valve, as you can see, goes all the way, and there is a common junction.
But Paolo makes a good point, because you could have the situation that the common AV valve goes exclusively into the left ventricle.
Yes.
So at some stage, this degree of override of the common atrioventricular junction is going to give you double inlet through the common AV valve.
Yes.
So Paolo makes a very good point there.
Absolutely, but not in this.
Not in that particular one. The problem that we have there, Paolo, is that we would have to use a 75% rule, and the mathematics come into it. So you have to take it with a degree of eyeballing.
Okay, I know. Just for a sort of how to tell things echocardiographically, sometimes you have a very high degree of overriding of the junction, even if it's common. No,
I agree with you, but you would eyeball it, wouldn't you? And
Okay, amazing. It was a great session, guys. I'm so proud. I'm so happy. I'm sure everybody enjoyed this so much. And guys, if you like this presentation, please share the YouTube link with your teams, and more people are going to be able